Thank you. Hello, everyone. And thank you, Jason Sending and Warakan for introducing me and for this prestigious opportunity. I'm Sung-Hae from Shizuoka Children's Hospital, Japan. Transcatheter heart valve implantation have expanded enormously in recent years. So in my talk, I would like to discuss what is currently known about the follow-up and antithrombotic management on that intervention. These are my disclosures. We should say that we have a nationwide comprehensive registry in Japan named National Clinical Database, which involves mainly surgical registries. It also includes our JSIC registry for pediatric intervention and concealed catheter interventions. Regarding the transcatheter pulmonary valve implantation, SAPIEN 3 and Harmony were introduced at an early stage through strong collaboration among the government, industries, academia, and the National Clinical Database. And post-marketing surveillance utilizing JSIC registry was a prerequisite for their introduction. As you know, approximately 22% of the all births to children with congenital heart disease result in some kind of RVOT dysfunction. About 25% of the RVOTs are repaired by Rastelli type surgery using a conduit or a bioprosthetic valve, and about 75% are repaired using autologous tissue or a transannular patch. So TPVI are roughly divided into two types: balloon expandable, which is implanted inside a conduit or a bioprosthetic valve, and self-expandable, which is implanted inside the right ventricular outflow tract of autologous tissue or with or without patch augmentation. The Melody valve was the first of these to be approved in Europe, and followed by the SAPIEN after 2010, and the Harmony valve in the US, and the Venus P valve in China, and the Pulsar valve in Korea for the self-expandable type. SAPIEN and Harmony and the Pulsar are all developed and approved around 2020. Of these, the SAPIEN 3 and Harmony valves were just approved by the Japanese PMDA in 2020 and 2021, respectively. They were introduced at an epoch-making early timing for us, comparable to that of the United States. In Japan, PMDA recommends to ensure that the new devices are introduced in consultation and collaboration with other related academic societies, such as adult cardiology and cardiovascular surgery. In transcatheter aortic valve implantation, TAVI, the Edwards SAPIEN 3 and Medtronic Evolut was already been introduced with an excellent result in Japan. And introduction of TPVI has been expanded from these TAVI devices. It is known about 25% of these post-operative patients with tetralogic Fallot and related heart disease are eligible for balloon expandable TPVI with a conduit or bioprosthetic valve, and about 75% are eligible for self-expandable TPVI with an RVOT derived from autologous tissue. SAPIEN 3 was introduced to Japan under a new system called Conditional Early Approval for Innovative Medical Devices, based on the excellent results of the Compassion and Compassion S3 trial in the United States. Harmony was introduced to Japan as a proof of concept in the Harmonization by Do It for Children activity, followed by the US-Japan joint clinical trial. In both cases, post-marketing surveillance utilizing the registry made the introduction earlier with still limited clinical data in Japan. SAPIEN 3 was approved in September 2020 in Japan. As explained earlier, the device will be implanted inside a surgical bioprosthetic valve or a conduit graft. The initial introduction from the PMDA was very strict indication criteria, and phase 1 treatment will be conducted at only 2 centers in Japan, followed by the 8 more centers in the next year. The target criteria are moderate or severe pulmonary regurgitation or pulmonary stenosis with a gradient of 35 millimeter mercury or more. In addition, the criteria includes patients are considered to be at very high risk for open heart surgery, such as history of multiple open chest. RVEF less than 45%, LVEF less than 45%, and RVESV index more than 95, or patient age older than 45. The Harmony valve was approved in Japan in 2020 last year and was introduced after the HBD for Children activity and the US-Japan joint clinical trial based on it. Again, Harmony targets RVOT with expanded autologous tissue, and the criteria are slightly different from those of the SAPIEN 3. Patients with PS are not eligible. In PR cases with a regression fraction of 30% or greater on cardiac MRI are eligible. The patients with the high-risk open heart surgery are the primary indication, and specifically those with impaired exercise tolerance or RVEDV more than 160 or RVESV index greater than 80 and QRS width more than 180 millisecond and so on. This is a part of TPVI specific registration screen. Procedural items such as measurements, selection of the valve and device size, and delivery sheaths and post-operative outcome, and follow-up items such as adverse events and device malfunction, and all other items necessary for post-marketing surveillance are included. Although there are a wide variety of items, the system is designed to be relatively easy to fill in by on-screen checks and numerical input. This chart illustrates the PMS schedule. The surveillance should be completed before and the procedure, and at the procedure, and 7 days after the procedure, and 30 days, 1 year, annually until 5 years after the procedure. Any kinds of adverse events and device malfunctions are defined in the registry, and we should report them every time. Okay, let's move on to the topic of antithrombotic management. I would like to start with the fundamental things as if I were giving a lecture to medical students as well as a review for myself. First, antithrombotic therapy is divided into antiplatelet agents and anticoagulants. The most common antiplatelet agent is aspirin. Aspirin irreversibly acylates COX-1, thereby inhibiting thromboxane A2 production in platelets. Aspirin rapidly absorbed, and during that time, it irreversibly inhibits COX-1 in all platelets in the bloodstream. As a result, the antiplatelet effect remains even after you discontinue aspirin. Platelets have a lifespan of about 8 days, so it takes that lifetime the platelets for the effect of the aspirin to completely disappear. Next, the first generation of the ADP receptor antagonists were the prodrug ticlopidin, which irreversibly inhibits P2Y12 by activating its substance in the liver. However, ticlopidin was known to have many side effects, such as leukopenia and liver dysfunction. Later, second generation clopidogrel, which was fewer side effects, was used. Cilostazol, a PD3 inhibitor, and dipyridamole, a PD5 inhibitor, are also commonly used, but both have moderate antiplatelet effects. Next, I will illustrate the anticoagulants. Our vitamin K antagonist warfarin was complicated drug interactions, dietary restrictions, and requires frequent blood sampling to monitor anticoagulant activity. However, each of the 4 DOACs, dabigatran, rivaroxaban, apixaban, edoxaban, currently available has proven to be effective and safer than warfarin in large randomized clinical trials. The results of these trials led to the approval to the DOACs, which have been available for clinical use since 2011, and they are steadily gaining acceptance in daily clinical practice. Next, we will discuss the targets of antithrombotic therapy. First, thrombi are broadly classified into platelet thrombus, in other words, white thrombus, and fibrin thrombus, in other words, red thrombus. I'm going to the details, I'm not going to in the details of the mechanisms, but platelet thrombus is considered more important in intra-arterial thrombus formation because it is a vulnerable system that functions more effectively under high shear stress due to action of the von Willebrand factor. Therefore, antiplatelet therapy is more effective in preventing myocardial infarction and cerebral infarction and treating peripheral arterial disease. On the other hand, fibrin thrombus is robust. Its formation involves a series of enzymatic reactions called coagulation cascade. The enzymatic reaction requires a significant concentration, which triggers thrombosis in slow-flowing vessels such as veins, but it's less likely to occur in fast-flowing situations such as arteries. For these reasons, anticoagulation tends to be more effective in preventing venous thromboembolism and deep vein thrombosis and cerebral emboli due to atrial fibrillation. Okay, from this slide, I will discuss antithrombotic therapy against prosthetic valves and transcatheter heart valves. As shown in the figure, we have currently these types of valves. A is a sample of a mechanical valve, and this particular figure indicates onyx valve designed to function with less anticoagulation. B is a bioprosthetic valve, internally mounted one. C is a bioprosthetic valve, externally mounted one. D is sapien TAVI valve, made of bovine pericardium. And E is evolute TAVI valve, made of porcine pericardium. This table provides an overview of antithrombotic therapy with prosthetic valves. Vitamin K antagonist is mandatory for mechanical valves in both the aortic and mitral positions. In the aortic position, the INR should be 2.0 to 2.5 because the blood flow velocity is the fastest, and clinical trials have shown that the more moderate INR of 1.5 to 2.0 is acceptable for onyx valve, which is high antithrombotic function. A slightly higher INR of 2.0 to 3.0 is recommended for mechanical valves in the mitral position. Clinical trials have shown that both thrombotic and hemorrhagic complications are more common with DOACs, so they are not used as an alternative to vitamin K antagonist. Because the high thrombotic and embolic risk during the first 3 to 6 months after the bioprosthetic valve replacement, vitamin K antagonist alone, INR 2.0 to 2.5 is recommended, regardless of whether the patient is sinus rhythm or atrial fibrillation. After that period, you can discontinue the antithrombotic therapy for the bioprosthetic valve, or in the presence of the atrial fibrillation, you should continue DOAC. And what about TAVI? Double antiplatelet therapy is generally recommended in the early stage of implantation, followed by the single antiplatelet therapy, and DOAC is continued if atrial fibrillation is present. This is a recent systematic review of antithrombotic therapy after the transcatheter mitral valve implantation. Thrombus formation is multifactorial, in other words, influenced by procedural factors, characteristics of the implanted transcatheter heart valves of various kinds, and underlying patient factors. Therefore, thromboprophylaxis after the valve implantation have reported in a variety of different ways, including vitamin K antagonist, DAPT, SAPT, and DOAC. This is one of the most commonly used DOAC, rivaroxaban. It is available in a variety of dosage forms, now approved in more than 130 countries. Very recently, the FDA and the Japanese PMDA approved rivaroxaban for treating venous thromboembolism and preventing recurrence in pediatric patients. As shown in this picture, you can get it with a suspension measuring kit. In each country, a table clearly indicates the dosage according to the body weight even in infants and newborns. As an antithrombotic agents after Fontaine surgery, we commonly use aspirin and anticoagulants such as heparin and vitamin K antagonists, but nothing is approved for use. Last year, the phase 3 Universe clinical trial showed that the treatment with rivaroxaban dry syrup in 2 to 8-year-old children undergoing Fontaine surgery resulted in fewer thrombus-related events compared to the treatment with usual aspirin. We obtained similar results from another clinical trial in Japan. Going back to the transcatheter heart valves, after TAVI, I mentioned earlier that DAPT is generally recommended in the early stage of implantation, followed by SAPT. and the same regimen is often applied after TPVI. However, I don't think it has been established at all after transcatheter mitral valve implantation and transcatheter tricuspid valve implantation. And this is the recent report based on the survey from multiple institutions performing TPVI. Following TPVI, 76% of respondents use only aspirin, while the remainders prescribe a second antithrombotic agent at discharge. Regarding the second agent, the most common was the clopidogrel, followed by the warfarin and DOAC. In the summary of my talk today, TPVI launched our country, and SAPIEN 3 was approved in September 2020 after excellent results of Compassion S3 trial, Harmony approved in August 2021 after US-Japan pivotal trial, both under the condition of post-marketing surveillance utilizing real-world data from our national registry. And we commonly use antiplatelet agents against platelet white thrombus, and we commonly use anticoagulants against fibrin red thrombus. We provide thromboprophylaxis to prosthetic valves, mainly by vitamin K antagonist, not DOAC. You provide thromboprophylaxis to TPVI, mainly by aspirin, however, may be replaced by DOAC. And in my opinion, DOAC will be more widely used in pediatric and SHD population in the near future. Thank you very much for attention.